Thanks for that marvelous talk, Spence. Very good. Our next speaker has presented us with some shocking data earlier in the meeting, and I think that the shock and awe is going to go on. He's going to tell us about what does all this stuff cost, and he tells me that he's not only going to speaking to us about it, but he's also spoken to people in the federal district in Washington. So please welcome back Grant Strapanik. His title of his talk is, What Does This Stuff Cost? Grant?
You know, I'd actually like to begin by taking a moment, a brief moment, hopefully, just to place this talk in its proper context. You know, one of the things that DEF CON really does is that it embodies the exchange and the development of new ideas, technological advances, but ultimately really a focus and care for the patient. Thursday, I really presented what I believed was a state of the union of the diabetic foot. And it's something that all of us in this room really understand. I don't know that outside of this room it's really well understood. But that the diabetic foot ulcers and complications are far too common and far too costly, both in terms of patient harm and the monetary outlays that are expensed for it. So today, what I'm going to present is what I believe to be a very, very important catalyst for change and for our efforts to continue not only to help the patient but also to help society overall. And that is to talk about costs. And cost is on one side a very simple term, but yet on the other perhaps one of the most complex and fundamental concepts that really exist in the economic sciences. And really with that, I would like to have a subtitle for today's talk, and that is Grim to Great: How Costs Will Catalyze Change. There have been a pretty good handful of studies, particularly over the last 5 years, that have focused upon what some of the attributes are of costs, and in particular the direct medical costs associated with the diabetic foot. You know, doctors Lavery, Addinger, and Jeffcoat have really done some pretty incredible work. I have read those papers extensively several times. I really hats off to that incredible work that's already been done. But Lawrence looked at the costs associated with implementing a diabetic foot team. Again, this is 5 years ago was published, and essentially found that the results for diabetic foot ulcers, that costs within the first year following the first ulcer episode were 5.4 times higher. Not surprising, 2.8 times higher the second year. For high-grade ulcers, that went up to 8 times versus low-grade. And that the supporting literature really indicated that a team approach to care, again, we were talking throughout the conference about coordination of care, can result in the reduction of long-term amputation rates by really remarkable 62 to 82%. Chris's study here, cost of DFUs across 5 countries, looking at Chile, China, India, Tanzania, and the USA. 2 scenarios were presented. One was an uncomplicated case, full healing at 8 weeks, and then a second scenario, a deep infection, long and progressive attempt at limb salvage. And I would just like to emphasize here, treatment costs, $2,010, standardized across international purchase power parity, as well as what the patient cost would be. Now, this is in terms of the month's income, and recognize that we have a lot of factors that are coming into play here, including the types of healthcare delivery and the types of healthcare systems. The United States, once again leading the world in costs. I would say that research has indicated about 90% of the reason that the United States has a very expensive healthcare system is because we're just very wealthy here. It's driven by GDP. There are other factors that come into play. Scenario 2, treatment costs in India. Look at that patient cost in terms of month's income. 5.5 years. 5.5 years of income. Now, we are a very patient-centered group of scientists and clinicians. That type of an impact, beyond the actual burden to the individual themselves, that's bankruptcy. We've got other work that we're working on currently under review, looking in the area of cancer and bankruptcy. And within 4 years following an initial diagnosis of cancer, we're finding that about 60 to 70% of individuals have spent their entire life's assets off. This is in addition to having insurance coverages. Almost 70%. So we see some real similarities here. A consulting group out of Boston, Diabetes Care 2013, looked at almost 30,000 Medicare patients and found that the additional annual cost of a diabetic foot ulcer was almost $12,000. For private insurance, almost 5,000 cases, about $17,000. And something very interesting here in terms of the work loss. This is just in disability days, not even looking at the loss of productivity if they're at work, something we call presenteeism, but over $3,000. Dr. Jeffcoat, looking at the cost of the diabetic foot to the National Health Service in England, about almost 1% of the entire budget. 53% went to the care of ulceration in primary or community settings, 38% for inpatient, and 9% for amputation. And this gets us to a review and a little bit of a deeper dive into the other analyses that we've conducted within the U.S. over the last decade. Again, diabetes almost equaling Medicare in terms of the charges that are associated with cases going into the inpatient setting, 2.5 million souls, so to say. The average cost per case of the diabetic foot, almost $50,000. And we see that the mean inpatient charge is absolutely going up. So is the complexity of case that is being presented to not only the emergency department, but also to inpatient settings, and the bill is continuing to go up. And this is the grim part, and I say, this is an incredible challenge, but as we all know, with those types of challenges come remarkable opportunities. The multivariable regression that we conducted on this really exemplifies that diabetes, like a number of other conditions, is a systemic disease. Such is the diabetic foot a systemic disease. That a number of the other cost drivers were comorbid conditions, in particular associated with coagulation disorders. I think there's a lot of steatohepatitis, liver problems. End game starts occurring when you've got end-stage renal disease, wasting syndrome, cachexia, and things of that nature. Some other findings, very important, and that is this is the grim part, no significant change in severe aggregate outcomes. But part of it is that, again, we're seeing a more complicated case presenting within the inpatient setting. So in some regards, there are some gains, but still very difficult to continue to overcome. Increased charges, about 16.7% for the decade, and shorter lengths of stay by almost a quarter. This is a little more detailed synopsis here of the role of comorbid conditions. And then, again, this is for charges. And again, charges are a proxy for length of stay and the intensity of care in terms of procedures. But as you can see, wasting syndrome, 61% higher. You would expect things like your anemias, your coagulopathies to also be very predominant drivers of that, renal failure as well. Upper and lower amputations, as you can see, 72 and 42% higher than other cases regarding the diabetic foot, and the change in time on the bottom. Length of stay really echoes that as well, with the exception that lengths of stay have decreased. So in some regards, things are happening better. People are getting out quicker. Something else, revascularizations. We have seen a dramatic shift in endovascular versus open revascularizations over time. As you can see here, almost a 300% increase for endovascular care. The percent of revascularization cases with amputation have remained relatively flat at about 25%. In terms of charges, you would expect these to be fairly high, especially with major amputations, approaching $150,000 to $200,000. Also reflective of length of stay. Something very interesting, and this was published, these results were published last year in the Journal of Vascular Surgery. For EVT and major amputation, we see that post-op complications. Now, again, post-op complication is not the end-all. Obviously, mortality would be an end-all. But we've seen a dramatic shift, almost 1,000% increase in the number of post-op complications associated with EVTs and major amputations. And yes, there is absolutely a more complex case that's presenting, but these results actually controlled for that. What's the message? It's not necessarily to say don't use EVT. It is to say be cognizant of these complications, manage them early, and so they don't occur. In terms of the emergency department, a little more detail here. But not much, because a lot of these results actually echoed the inpatient analysis. You would expect emergency department costs to really resemble that. Those that resulted in an admission, again, you would expect to be much higher than others. What we did find is that the caseload has really increased of individuals relying upon the emergency department as a place of care and a point of service. Those that are treated and released, about $2,000 transferred to other facilities. Both of those we saw a dramatic increase from 2006 to 2010. Major and minor amputations, you can see the differences in cost here, and mortality. You know, why are these types of figures even important? We are going to shift to talk about more the philosophy and the technical aspects of what costs really are. To me, these are interesting. They're secondary types of outcomes. What they do is they help present a case for all of the important work that we're doing to establish cost effectiveness. And there is a dearth, there is an incredible need for us to continue to move forward to establish what cost-effective practices and technologies are. Because that's when people listen, is when you can actually show that there might be patient harm in terms of an inappropriate use of these scarce resources. That's why these numbers are important. Not just in themselves, but because they help drive the right types of things to happen. You would expect that, again, this is sort of a graphical reflection, amputations followed by mortality, admissions, and then your treat, release, and transfers on the bottom in terms of mean charges. These are just selected findings. I'm cherry picking here, but still interesting. And this is controlling for income, this is controlling for geographic region, this is controlling for urban versus rural settings. But Medicaid versus Medicare recipients in the country. Longer lengths of stay, typically higher charges. More complex cases, they're staying in longer. What's going on? The issue is often, believe it or not, even though the Medicaid population is often younger, their comorbid conditions are typically more severe, and they're more often poorly managed. So again, a coordination of care for the systemic disease of the diabetic foot. Treat and release cases, we've seen, again, more intensity here in terms of those charges associated with someone presenting and sending them home, also transfers. Admissions, shorter lengths of stay. So the prelude, what are costs? Why are they important? Well, in terms of why they're important, it's for adoption, reimbursement, and utilization. That we look at the efficacy, safety, if it's a pharmaceutical or a biologic, the purity of those agents. We conduct things like health technology assessments to say we're going to not focus on a very naive approach to understanding healthcare in any country, on any continent. 10 to 15 years ago, I did a lot of the initial work on oral chemotherapeutic agents. These are the ones that you are well aware of. $50,000, $100,000 a year. That's expensive. It's expensive, but believe it or not, a lot of those treatments are cost effective. That not only did they lower overall costs, but they improved outcomes. So if you take a naive approach and say, oh, they're $50,000 to $100,000, we can't use them, ultimately you're going to be really, really hurting the welfare overall of society by doing that. And we need to begin to really, this is an inflection point, I think, over the last several years in a number of disease states, and nowhere more important than the diabetic foot, to work together, to band together, to push the science, to push the methods, and actually put in front of legislators and key decision makers cost-effective approaches that will actually benefit patients. So what are costs? Well, good luck. The more I learn about what a cost is, the more trouble I have understanding and explaining it. It makes me wonder why I was in school for 30 years, right? Costs are one measure of resources that are consumed. What's a cost versus a charge? Well, what's a cost versus a price? What's a cost versus a burden? These are all different things. It's basically, how are you defining cost? The question I always ask about cost is, who pays when something goes wrong? I heard that cost, in terms of a provider taking care of the diabetic foot, was a sunk cost. A sunk cost is one that is gone forever, that you just ignore from any future decision making. And I would say, from when I was at Baylor and I did my training in the NICU, in the emergency department, and then ultimately in cancer, I would spend time and say, doing the right thing would actually put this entire institution into bankruptcy. So what are you incentivizing with some of these reimbursement schedules? We are moving to bundling. We're moving to more capitation. We're moving to very different mechanisms, some of you with monitoring devices and other forms with 510 or de novo approaches. We have to continue to push this science. And accounting costs, and these are the ones that your chief financial officers, unfortunately, and legislators often focus on. It's the wrong cost. These are monetary outlays. These are the costs that appear on the book. This is your oral chemo drug for $50,000 to $100,000, and that's it. Now, an economic cost is actually how decisions are made. It's where you look at alternatives, and you consider the global costs as well as the outcomes that are associated with that. If I'm going to make an investment in real estate versus diamonds versus art or versus the stock market, I will consider all of the risk and rewards and then make a decision on the opportunity costs or the opportunity loss of any one of those decisions relative to the other one. So economists are concerned with opportunity costs, and these are not naive by any regard, and these are very comprehensive and actually take a little time to obtain. An opportunity cost is the value of a foregone alternative, a lost opportunity. These are the ones that are most crucial to decision making. It must be forsaken to obtain something by way of purchase, exchange, or production. Cost to whom? Cost to a patient? Very different than a cost to a provider. A caregiver time or lost productivity time may be costly to an individual with a diabetic foot or to society, but as a practitioner, might not even matter. It doesn't matter that it's going to take 6 hours to get to the clinic. Just get there and I'll bill you, right? I've highlighted society because there's a real lack of literature that embodies all of the perspectives and all of the costs, and we really need to move in that direction to find out what the impact of the diabetic foot is on society. Primary categories, we're often focused on the bill, the direct medical costs, but there are other ones. There are indirect costs. Those are the ones that are relating to lost productivity. And yeah, as a matter of fact, I can put a cost on your happiness. Intangibles, reflecting the patient's lack of a level of pain and suffering and lack of happiness. And the way that you actually do that is that you place preferences in front of a patient and the values that they attribute to that. Very patient-centered. You can do it, and it's done in a number of ways. I'm presenting something that we're working on right now, beginning here at this conference, and it's a conceptual framework, not for cancer costing episodes, but for the diabetic foot. There's so much that goes into costing a cancer episode. Look at this. It's small and unreadable on purpose because it involves not only pre-cancer, but survivorship and bereavement and a number of other things. Yeah, as a matter of fact, to a patient, this is what matters. Very important example of how we do cost. It's not just the cost of a product or the procedure, but take a look at the bottom here. The cost of managing adverse events. The cost of treatment failure. Critical. That's the most difficult thing for me to impress when I'm trying to put my clinical hat on and say, you know what, the cost of a treatment failure is often the one that drives costs. So great, we're going to use an old, archaic type of procedure. It's not really going to work. Yeah, as a matter of fact, it would make common sense that it's going to cost a lot because you've got to follow up with other things. But you know, on a budget, that might not be considered. There are also ways to cost outcomes. And these are outcomes that are important to the patient. And that is, what are the monetary benefits of having an improved health state? You lose a limb, good luck trying to get work afterward. Not only the mental state that an individual will be in, but also the physical impairment that can occur. Yeah, you, as a matter of fact, you can recover in many ways, but that is a lot to really overcome in terms of your work productivity. A huge societal impact. We put all of this together as in economics into something that we call an incremental cost-effectiveness ratio, and it's again illustrating why it's not just the cost of a product or service, but it is the total cost of care. The total cost of care, including failure, side effects, everything else. And then we place that against the next relevant comparator. And then we balance that with outcomes. And oftentimes our outcomes can be a treatment success, a life year gained, or some obscure thing called a quality-adjusted life year, where we measure people's utility or happiness. This is the direction we're going, and this is what's going to be at your doorstep very, very soon, because it's been there for about 20 years in other disease states. And then we graph it. We graph an existing standard of care and all of the scenarios that can occur with a new technology, whether or not they cost more, they cost less, or improve outcomes, or not. This particular scenario shows that you save money and you improve outcomes, and basically you'd be a dodo if you didn't choose this technology versus the other, even if it did cost more to acquire it. And I want to conclude, not by a summary of what we've talked about, but a summary of what we presented last year, the cost of doing nothing. In the last year since we've presented this work, the foot and wallet disease, it's been published. We have been interviewed by the Congressional Budget Office. I was moving to Oklahoma. Dr. Mills and Armstrong were summoned to the governor's office, so thank you for doing that while I was moving. But this research, to summarize, if you were not here last year, measured in fairly dramatic form what happened when the state legislature in Arizona decided to save money, $351,000 in reimbursement to podiatrists for Medicaid. They needed line item things to cut. So they cut this. And you can see the graph. It happened almost immediately. In Medicaid, we saw that where individuals ended up was the hospital. We saw a near 40, this is a This is not raw numbers. These are adjusted numbers controlling for other factors. How sick individuals were, their age, their gender, and so on. 40% more admissions. We also controlled for just overall trends in because the critiques we've got were really interesting. When I said, well, the reason that you saw this increase is because so many more people enrolled in Medicaid in Arizona. Well, you know what? We controlled for that too. Near 40% higher admissions, 37.5% higher charges, longer lengths of stay, and the real unfortunate cost of this, near 50% higher severe aggregate outcomes. So the $351,000 ended up being spent in $16.7 million in inpatient costs. So this is why costs are so important. From grim to great, why these are going to help catalyze all of the change that we're working on. Thank you.